A very warm welcome to everyone that is joining us today. I can see that participants are coming in. Jill and Bradley will be monitoring that for us. My name is Andan Zuza, Research Technologist at the Gender and Health Research Unit at the South African Medical Research Unit. I'm a project coordinator for the Forgotten Agenda study, which focuses on sexual reproductive health research for young women with and without disabilities under the COVID pandemic. Our team lives and works in Durban on the east coast of South Africa. My personal pronouns are she and her. You can share yours before you speak if you would like. First of all, I'd like to thank you today for joining us this afternoon. For some of you, it might be evening or morning, of course. So this is our third Forgotten Agenda webinar. Our third Forgotten webinar agenda is placed in a month where we celebrate Human Rights Day. This day is commemorated annually to remind us South Africans about the sacrifices that were made to attain a democratic South Africa in which all people have equal opportunities to make the most of their lives. However, despite our best efforts, some people, such as people with disabilities, do not yet enjoy life on an equal basis with others in the society. Globally, reports have shown that disability-based inequalities have deepened during the COVID pandemic. However, data and information on how people with disabilities experience the COVID pandemic are not widely available. Often data collection on disability is an afterthought, hence a forgotten agenda. Today, we want to share with you research with people with disabilities under the COVID-19 pandemic in South Africa. We will explore what we know and how we can improve our response in times of crisis. In order to do so, we have compiled a webinar that will share research from the National Department of Health and Human Sciences Research Council and our Forgotten Agenda study. The Forgotten Agenda study is conducted in eThekwini, South Africa, with young women with and without disabilities during the COVID-19 pandemic. This study also identified other key research focusing on disability, as well as good practice examples in sexual reproductive health and rights and disability during the pandemic. These we will share with you today. So during today's webinar, we will hear from Dr. Pravina Sukhrajeni, who's the Chief Director in Governance and Compliance, Department of Women, Youth and Persons with Disabilities, who will give us a keynote address on disability inclusive policy development. Then we'll hear from Dr. Tim Hart from the Human Sciences Research Council, who will talk to us about how South Africans with disabilities dealt with COVID-19. Thereafter, we will get a presentation from Professor Johannes Hancock from the Gender and Health Research Unit at the South African Medical Research Council, who will look at sexual reproductive health and rights of young women in South Africa, with and without disabilities under the crisis, particularly during the lockdown level 5 and 4 in 2020. I will then facilitate the question and answer session with the assistance of Nokolo. Thereafter, we will hear from two good practice examples, one from Jacqueline Kashula from Africa Rehabilitation and Research Consultants, and one from Dr. Jacques Lloyd from the National Department of Health. I will lead us over to our first speaker right now, who is Dr. Pravina Sukhrajeni, who will give us a keynote address. Dr. Pravina Sukhraj holds degrees in law, political science, and has a PhD in public policy. She is an advocate at the High Court in South Africa since 2004 and is currently the Chief Director and Governance and Compliance at the Department of Women, Youth and Persons with Disabilities. Dr. Sukhraj will now share with us the department's knowledge on how interventions during COVID try to promote safety and protection to those with disabilities. Over to you, Dr. Sukhraj.
Warm greetings. Thank you, Ayanda. Warm greetings from Pretoria. It is an honor for me today to represent the Department for Women, Youth and Persons with Disabilities in this important webinar. The protection and safety of persons with disabilities during situations of risk, national disasters, and humanitarian emergencies is a priority for our department and for government. As we are aware, on 26 March 2020, the President declared a national state of disaster and summarily put the country on lockdown due to the COVID-19 pandemic. The purpose was to put measures in place to mitigate and combat the spread of the virus to ensure, by ensuring safety and protection of all persons with and without disabilities living in the country. It rapidly became apparent, however, that the global crisis of COVID-19 deepened the pre-existing inequalities that existed among persons with disabilities and further exposed the extent of the exclusion. Moreover, it was highlighted that the commitment to disability inclusion needed to be prioritized and strengthened. Article 11 of the UNCRPD requires that state parties must put measures in place to ensure safety and protection of persons with disabilities during situations of armed conflict, risk, national disasters, and humanitarian emergencies. The requirements of Article 11 have been embedded in the White Paper on the Rights of Persons with Disabilities, which serves as an instrument to develop mechanisms for domestication of the UNCRPD. The Department of Cooperative Governance and Traditional Affairs issued Regulation 11B7 under Section 27(2) of the Disaster Management Act in April 2020 in order to prevent and combat the spread of COVID-19 in the country. These regulations also applied to persons with disabilities. Furthermore, to greater understand the needs of persons with disabilities during the pandemic, the DWIPD, in partnership with the Office of the High Commissioner on Human Rights in Southern Africa, conducted research to study the socio-economic impact of COVID-19 on persons with disabilities in the country. This research study provides an analysis on how various interventions were provided by state institutions to try and promote safety and protection of persons with disabilities during the national state of disaster, and how South Africa complied with the requirements of the UNCRPD and policy briefs issued by the World Health Organization and the UN with specific reference to disability. This research report also captured and experiences of persons with disabilities themselves and made recommendations for disability inclusive, disaster responsive measures in relation to various thematic areas, including access to information, access to education, health, social services, safety and security, economic opportunities, transport, consultation and participation, including access to quarantine and isolation sites. The research report was published and has been released by the Minister of the Department for Women, Youth and Persons with Disabilities in October 2021 and is currently being processed through various cabinet structures for consideration. I want to briefly highlight some of the recommendations of the research report. During national disasters and situations of humanitarian emergency, it is imperative for persons with disabilities that their safety and protection is prioritized, including in institutional settings and in residential care facilities. It must also be ensured that women and girls experience gender-based violence rights are protected during situations of disaster. Government must ensure access to basic services, including access to screening and testing sites and quarantine and isolation facilities. Furthermore, it is vital that information and communication materials are provided in alternative formats, including Braille, easy-to-read format, sign language interpretation, subtitles, etc. And most importantly, all platforms, including social media platforms, must be accessible. Government institutions must ensure that all persons with disabilities benefit equally to all employment and economic relief measures implemented. Employers of persons with disabilities must ensure that reasonable accommodations and flexibility is provided to persons with disabilities. Social grant and social relief remedies must be provided, for example, provision of food parcels, etc. PPE, including access to screening methods and procedures, must be provided. Safety of learners at special schools, including at hostels, must be prioritized. All government departments must obtain special disability data in order to develop evidence-based and appropriate interventions and support. The recommendations of the research study will assist implementing state institutions in all spheres to adopt effective policy measures for safety and protection of persons with disabilities, to plan for and prioritize disability rights during current and future humanitarian emergencies and states of disasters. Together, let us build a South Africa which is inclusive of all disability rights. Thank you, Ayanda, for this opportunity.
Thank you so much for this inspiring keynote, Dr. Pravina. It is great to see how the department tries to use research to inform practice. Now let's look at some research from South Africa during the COVID-19 pandemic. For this purpose, I would like to introduce our next speaker, Dr. Tim Hart. Dr. Hart is a doctor of social anthropology and currently works on disability and food security rights in the Development, Capable and Ethical State Research Division of the Human Sciences Research Council, South Africa. Together with the Institute for Development Studies in the UK, the HSRC conducted an internet-based survey with people with disabilities in South Africa. Dr. Tim Hart will now share his presentation on South Africans with disabilities experience of COVID-19. Over to you, Dr. Tim.
Thank you very much, Ayanda. And I'm very happy to be here today to talk to everybody and to share the findings of our study. And I will try to keep it very concise and to the point. Just one note, the study was also done in conjunction with the National Council for Persons with Disabilities in South Africa. Next slide, please, Joel. Okay, so the research specifically looked at socioeconomic well-being, human rights-related experiences of persons with disabilities in South Africa. And we collected data through an online voluntary survey, and we had 1,857 valid responses. Okay, there were close to 2,000, but some people had signed up to the survey and then decided to withdraw, so we couldn't use their data. It's probably one of the largest data sets on people with disabilities during COVID-19 in a single country. I've been presenting on this work now for about a month, and most other surveys are much, much smaller samples. Next slide, please, Joel. Next slide, please. So, as a background to the study and what motivated us to get involved into looking into something about human rights was that the data is rather conflicting about how many or what proportion of the South African population have some impairment that could make them disabled in certain environments. Okay, so there's between 12 and 20% and of the population, and the jury seems to be out. Some surveys, national surveys, put it still around 7%, 8%. There are estimates that it should be higher, more in line with the 15%, which is a global figure. But one of the South African surveys earlier this decade put it at around 20%. So COVID-19 arrived on our shores and there was a lockdown, as mentioned just now by the previous speaker. And we wanted to know what was the impact on persons with disabilities in South Africa. Initially, or initial reports were that they were being overlooked by disaster relief interventions and programs. The pandemic directives ignored their situation and circumstances. This resulted in regulations that aimed at controlling the virus, impacting negatively on their life, daily living and well-being. Okay, neither the Disaster Management Act nor the Disaster Management Framework actually acknowledge people with disabilities or that they have diverse needs different to other vulnerable groups in the country. Rather, the Act and the Framework just speak about vulnerable groups per se and don't go into any detail about the different vulnerable groups we have. We also noted that stipulations of Section 3.5 of the White Paper on the Rights of Persons with Disabilities implementation matrix relating to disasters was far from complete. Discussions with some people in government departments were saying that very little had been done, and although the matrix had been drawn up, there was no fat to the bones, and this was causing problems during COVID-19. Next slide, please, Joel. So our methodology was really an online voluntary self-administered survey, and this obviously has some associated weaknesses with, as any survey would, and also when it's a voluntary one and it's online. And we had to comply with COVID-19 regulations and also with our own research ethics committee recommendations. So that is why we opted for the online self-administered survey. There was strong collaboration between the National Council for Persons with Disabilities, the Human Sciences Research Council, and the lead partner, the Institute of Development Studies in the United Kingdom. Our view generally amongst the entire team is that the process was very collaborative and there was really good knowledge exchange, and all three partners were involved in the design of the survey instrument, sorting out the logistics behind that, and in getting people to complete the survey. But I think the greatest contribution towards the access goes to the National Council, because they used their networks and their APDs as well as other disabled persons organizations within their broader networks. We also use some of our own individual and other network partners that we had, just to ensure that this survey reached as many people as possible. And as I said earlier, we had 1,857 valid cases. So if we look at the high-level key findings, we see that there were communication challenges that were experienced by many. Very little government intervention and a large reliance on the disabled people's organisation sector and other non-government organisations, especially when that came round to NGOs that provided health and food security. Communication about coronavirus and the monthly meetings monthly on Sundays seem to be inadequate for certain types of disabilities, as most people reported relying on television to get most of the information about the coronavirus and about the regulations that were continually changing as we moved through different phases of lockdown. Captions were not existent. South African Sign Language interpreters were not always visible, and some people reported having language challenges because the medium of the message was only in English, so there was some language challenge there. The result was confusion about interventions and the services available and where to get them. The perception generally from this part of the survey and other questions in the survey was that interventions were far from disability inclusive. Next slide, please, Joel. So our second lot of high-level key findings is we were asking people about the negative impact that COVID-19 had on their economic well-being. And if you have a look at the graph on the right-hand side of the slide, you'll see that at the time of lockdown on the 27th of March, we had 37% of our sample were employed full-time, part-time, self-employed, or had casual employment. So that 37% of the entire sample actually had some form of remunerated or financially remunerated employment. 35% were unemployed. 9% said they were unable to work because of their disability. 8% were students. 6% were looking after households but were not being paid to do so. 2% were pensioners and received a grant either from their own funds or from the state. And 2% said that they were unable to work because of health conditions. So during the actual rolling out of, no, not the rolling out, but rather during the first 15 months of COVID-19, when our survey started, that was the end of the first 15 months, a lot of people said that there'd been quite a lot of negative impacts on them, on their economic circumstances. So 13% lost their jobs, 11% were working at reduced pay, and 6% had to take compulsory leave. And some reported a negative impact on their own businesses due to the initial closure of businesses or non-essential businesses during the first 2 months of lockdown. Okay, 31% of the respondents were receiving a disability grant, but 33% were receiving this SRD grant, which often replaced the temporary disability grant for many. All right, and 10% were receiving the old age pension or elderly persons grant. Next slide, please, Joel. So what we found is that at least 63% can be considered very poor, living on an income of less than 5,000 per month. So if we look here, we'll see that the highest share of, the highest share of single share of people were living on an income between 2,500 and 5,000 rand a month, but the majority were, the 63% were living on between, or let's say less than 561 rand per month and 5,000 rand a month. Okay, and you see that if you look towards the right-hand side of the chart, you will see that much smaller figures for people earning between 5,000 and 10,000, those earning between 10 and 20,000, and those earning between 20,000 and 40,000 per month, and only 1% had more than 40,000. Some people didn't know because their finances were often managed by somebody else in the household. Next slide, please, Joel. All right, we asked people to identify from a list, so it was a multiple response question, experiences that they had not usually experienced prior to COVID-19. And here we see that 39% people reported that they had gone to bed feeling hungry at some stage between the 27th of March and the end of August when our survey ended, okay? Someone else in the household had gone to bed hungry, also 39%, and 40% said that they ran out of money to buy food. But perhaps the most shocking thing is that in July and August, when we ran our survey, 29% of people reported that during the previous 7 days, they or somebody else in their household has gone to bed hungry. So this means that quite simply, after the government interventions to deal with the pandemic and the rolling out of food parcels and so on by both government but mainly by the non-profit sector, we still have 29% experiencing food security that they had not experienced before the 27th of March. Other things that affected people was running out of soap or hand sanitizer, having problems getting water, being unable to get public and private transport when they needed it to get to health and rehabilitative care facilities. Only 12% in the entire sample reported having none of these problems that we listed here. Okay, next slide, please, Joel. So 76% of people reported difficulty in paying for basic living expenses, and they noticed increases in disability expenditure. So this includes hygiene services, sanitation, and medication. Some people require special cleansing chemicals, and others require medication, and they had a problem getting these because they're often allocated to people who had COVID-19, and this prevented them from getting access. There were restrictions at pharmacies that also posed a challenge. So 60% were reliant on a daily carer service, and 73% of the 60% reported that these had been interrupted, usually from 1 day to around 2 months, okay? But some people even reported, I think a small percent of 1 or 2% reported that the service was still interrupted during the time of our survey, largely due to not wanting to, either they didn't want to get ill or infected from COVID-19, or their carers didn't want to come to their houses in case they got COVID-19. So we also found that disability-specific services were also interrupted. So this was largely with regard to repairs to assistive devices. These were delayed for the first 2 months, but there were also counselling services were delayed, treatment that people needed, such as rehabilitative treatment, physiotherapy, and so on. And those were all delayed for at least the first 2 to 3 months. And people had problems when that was, when those embargoes were removed. They also had some problems because of trying to get transport to these services. Psychosocial experiences, people reported, or 60% reported feeling stress, 54% reported depression at some stage, 52% reported being anxious or scared, and 42% reported being lonely. often due to limited social interaction, as many live alone, but also because many, as we know, 60% were reliant on a daily carer, and if this person was not available, they would have nobody to communicate to on a face-to-face basis. Most government and other providers were considered by 48% of the sample to be doing a poor job, and this was up until the end of August last year that people felt this way. 37% of the respondents relied on the state at the beginning of lockdown, but there seemed to be a greater movement towards the disability sector support organizations, with a shift towards 51% of people saying that they were now more reliant on the disability NGOs for support. Next slide, please, Tom. So in conclusion, the Disability Rights Disaster Framework is far from complete, and this needs to be completed urgently. The pandemic is by no means over, and we need to put the meat on the bones. They're still seriously lacking meat, so that needs to be done. Many people have been overlooked by many interventions, so this leads us to the conclusion that there's a lack of disability inclusive approach in how the interventions and also the regulations were introduced. The mitigation and control regulations had negative consequences on rehabilitative and other services, as I mentioned in the previous slide. And clearly the diversity of people within the sector of those persons with disabilities is ignored. We're all different. We all have different needs, and this diversity has not been taken into consideration. Information and interventions need to become more accessible, and it seemed to be that those who are already on the system, such as those receiving grants, tended to be more up to date in terms of getting information. Possibly there was more recent contact from SASA or the Department of Social Development about the services and interventions available. There seemed to be little interaction or collaboration across departments and also with DPOs. There was some interaction with private sector, but this was really insufficient, is what our findings indicate. So while a lot of claims have been made about the data-driven response to COVID-19 globally and also in South Africa, there seems to be a lack of disability data to direct how the response to COVID-19 can be made more disability inclusive. And 83% of the respondents felt that government should monitor circumstances of persons with disabilities during pandemic. This was to ensure the continuity of services and also to monitor the protection of their rights. Thank you, Joel, and thank you everybody for taking the time to listen to me. And once again, many thanks to my colleagues who helped in drafting with us, and to the funders, and to everybody for attending. Thank you.
Thank you so much, Dr. Tim. Your presentation really highlights the deepened impact on poverty disruptions of access to disability and rehabilitation services, and the importance of disability inclusive research. One of the aspects that we often hear little about in disability research are the sexual and reproductive health and rights of women with disabilities. Hence, adding to the previous speaker's findings, we now add the forgotten agenda findings. For this purpose, I would like to introduce Professor Johannes Hancock, who is a senior specialist scientist at the Gender and Health Research Unit at the SAMRC. She focuses on disability and sexual reproductive health and rights, and is the principal investigator of the Forgotten Agenda study. Professor Jo will now share with us the first findings from our study, focusing on sexual and reproductive health and rights of young women with and without disabilities. Over to you, Jill.
Thank you very much. My name is Jill Hancock, and my personal pronouns are she and hers. And yes, I will share today some data on our study on sexual reproductive health and rights of young women with and without disabilities under crisis. Before I go there, before COVID-19, we already knew that in South Africa we have a HIV epidemic, which is particular, the new infections are particularly driven by young people and here young women. We also knew that people with disabilities, that the prevalence amongst them is, for instance, higher than national average. From other studies, we know that this is particular women with disabilities and that this is driven by gender-based violence and transactional sex. We also know from the What Works program that women with disabilities are 2 times more likely to experience intimate partner violence and that than their peers without disabilities, and that at risk increases with severity. And research also indicates that young people with disabilities in particular lack access to sexual reproductive health services and comprehensive sexuality education. So of course, we were now interested to see what was that like under the COVID pandemic. So in order to do so, we wanted to describe the impact of the COVID pandemic on the lives of young women with and without disabilities and their need to access sexual reproductive health and rights. So that contributes well to what Tim already has shared with us. So for that, we identified the sexual reproductive health needs, the services that were accessed under the pandemic, and different lockdown levels, similar with the experience of violence. And we tried to identify some good practice examples, some of which you will hear today. In South Africa, and Tim alluded already to that, we had at the beginning of the pandemic a very hard lockdown where many people had to stay at home, or we had a stay-at-home order. And a lot of the things I'm sharing today reflect on that particular time in 2020. So, seconds. So what did we do? So we conducted a longitudinal study following a smaller group of young women with and without disabilities between the age of 18 and 26 who had completed grade 12. That allowed us to make a little bit of comparisons. But it was also based on the fact that we had already a group of women without disabilities prior to the pandemic, which we could approach for this study, and then use the same kind of approach of recruiting them with the women without disabilities, which was basically we approached universities, colleges, FET centers, and then afterwards peer-to-peer recruitment to get these women to work with us. We conducted a series of two telephonic interviews. That is what was mostly available at the time. And sometimes we had to do face-to-face interview because that didn't work. We used validated skills, sets of questions, open-ended questions, and photo voice. So it was a mixture of quantitative and qualitative methods of inquiry, which then collected information on demographics, living conditions, food security, mental health and coping, the experience with COVID itself, and obviously the access to sexual reproductive health service and exposure to violence. We took then that information from the different data sets and developed case studies, once for each individual woman through triangulating their photo voice, quantitative and qualitative data, and then developed case studies of group of women. Today I'm sharing those with and without disabilities. So next slide here. So what did that sample look like? So on average, the age of these women in 2020 was between 21 and 22 years old, similar for women with and without disabilities. Most of them were studying. Some of the women with disabilities had just completed their studies, while some women with disabilities were about to start studying. Women with disabilities, few of them had an intimate partner at the time of interview 1. And more than without disabilities. And that interview took place similar to Tim, like after the hard lockdown, and then reflecting on the time before and after and during the lockdown. We also took some measures in terms of seeing what the mental health of those young women was like, and most of them actually scored as with depressive symptoms at the time of interview 1. We also looked at their living conditions, which were during lockdown relatively similar in very large families. But before the lockdown, those women without disabilities had more the experience of living in student residence in smaller spaces. So now I will share with you the results from the first interview. That is the one that was done after the hard lockdown in 2020, and collected data on livelihoods, covert, mental health, sexual reproductive health, contraceptives, and violence. So first of all, I give you an impression with the photo voice, what the woman sent us as one of their first things to express how they felt during the hard lockdown in the pandemic. From the woman without disabilities, we got quite a very mixed bag of pictures. So we got some that expressed that they were sad and anxious and they had to somehow study. Others expressed, oh, it was a nice time to be with the family. I could do something different in gardening, because many of them went into rural areas. And some keep themselves busy with doing exercises and other activities. From the women with disabilities, we got a very different feedback of pictures, many of them expressing sadness, anxiety, and sometimes even anger. And there was, I think, only one who shared an activity that they actually did. And I will say something to that a little bit later, because it triangulates well with what we got from the other data. So, first of all, the impact on the stage of life of these young women was quite significant. And I just recall, they are between 18 and 26. These are a group of young women who can actually access tertiary education. So their life would have been under normal circumstances, going to varsity, going to college, going to a training center, learning something, interacting with other young people, and maybe go out and have fun. But instead, many of them moved back into their large families in rural areas. In some ways, it was a safety net for them, but it also was a loss of independence, particularly for the women without disabilities who had more experience of independence prior to the pandemic. They did, as I already mentioned, they did keep themselves busy with activities, particularly the women without disabilities, board games, gardening, exercising, while we had much less of that from the group of women with disabilities, who often then also reflected on being isolated or just watched TV. All the women experienced multiple challenges of studying. Remember, this is predominantly students. So they felt isolated, they felt they had challenges with accessing data and the internet and the network. They had very little physical space, many studying on their beds in order to move forward, particularly in rural areas. But on top of that, it's because they are women, they also experienced a double or triple burden. So they were supposed to study under those circumstances, they were supposed to do household chores, and they were supposed to do facilitated childcare. Some of them also really reflected on being lonely, and that was particularly in the group of women with disabilities like this, and missing their friends. And some also talked about really milestones, like I could have graduated now, I don't have access to my certificate, my ability to seek work is now delayed, or it is impossible. So, and here are two examples of a quote. The first one is, "The connection, internet is bad, and we are living together with the family, and most of the time I have to do the chores in the house. And when I'm trying to study, the kids are disturbing, making the noise. So it was a bit challenging, and the data, so internet data is expensive, so it has changed a lot." That was a woman without disability. A deaf woman with disability said, "I was bored and it was quiet at home, nothing to do, no communication with family." They obviously can't speak sign language. "I read magazine, watched TV, cleaned the house and exercised." In terms of food security, something similar to what Tim already alluded emerged. Although this group didn't have tremendous challenges with food security, when they reflected on the lockdown, they didn't have any before. When they reflected during the lockdown, they did have days when they lacked food. And that was bigger for the group of women with disabilities than those without disabilities. Also during that time, the access to support structures such as food parcels or the COVID disaster grant increased for both groups. And when we asked them, you know, what do you live from? How do you make ends meet? Most of these participants were in some form of student grant or stipend. So in South Africa, we have the NSFAS, but for those with disabilities who don't go to universities, there's also grants that are the specific centers, in this case, EDF and ICANN. Some women also had access to the child support grant. And these support grants really supported the livelihoods of these families and the food security, and in one case, even the building of a house. People made also access to COVID relief grants and food parcels, as I already said. For those people with disabilities who access only the disability grant, who didn't get a student stipend, this disability grant also really supported families. And then what you saw a lot in the rural areas is that, and that's particular women without disabilities, they started gardening and increased the food security that way. So they took lots of pride in it, and it seems to have really worked for people. Yeah, and overall, I already said the women with disabilities reported more challenges. I'll give to you 2 examples. My sister and I get the NSFAS, so that's a student grant, and the social grant. We combined the money and bought lots of food at the beginning of the month so that the food would last us longer. And those who are working contributed, and my grandmother contributed, so we would have food that would last us longer, women without disability. And again, a deaf woman said, it is hard. There's not enough money to buy food. My family really relies on me for money. My boyfriend doesn't help me enough because he goes to the bar every Friday to drink. So this is a woman that also went back to her boyfriend. In terms of mental health, I already mentioned that the woman really had a number of sad experiences, that there were more mixed emotions with those without disabilities, and that most of them scored on the CESTI-10 with depressive symptoms. What is interesting is that they also reflected on the anxiety and the lack of information about COVID, and the importance of their family for safety and togetherness to actually go through that hard lockdown period. Very, very few participants actually accessed any mental health support, and usually family, friends, sometimes religion, and often really self-motivation were the support mechanisms of these women in both groups. Using 2 examples, I talk to friends and people close to me when I'm feeling sad and lonely. The thought of the future and not being employed depresses me. Not knowing what to expect stresses me. Workload at a new job and not knowing anyone. A woman without disability. Now, a woman with physical disability described, and I was worried about my future because my varsity life before Corona was already a mess, as I was in and out of hospital. So when Corona came, I said, there is no way I will finish this degree. I was devastated. I used to cry at night. I would call my mother and say, you know, today I feel like taking my life. Then she would motivate me and uplift me. The experience with COVID, many of the women explained that either they or the family member had some symptoms, but there was very, very little testing. They often self-diagnosed a common cold and used home remedies to manage it. But yet there was a lot of anxiety. There was also misinformation about COVID, as well as misinformation about testing and vaccines reported. So there's again 2 examples. Woman without disability explains here that it's when we will consider going for testing if the flu became more serious. But if the flu goes away, we just move on with our lives and never get tested. A blind woman explains, we had cough and fever, but we did not test for COVID. You may have been negative, but at the clinic, the test will say you are positive. So you see a little bit of the misinformation here and hesitancy of COVID testing. So now when we come to the usage of sexual reproductive health and rights services, in this group, I think there's 2 interesting things to be said. So first of all, there was a difference before the hard lockdown, or before COVID, with women with disabilities being less, they accessed less these services. But remember, they also there were less of them that actually had a boyfriend. So maybe it has something to do with that. And then for all of them during that lockdown, for all of the different services that one could access, for most of them, that usage went down during the hard lockdown, but also the months afterwards. So when we asked the woman why that was the case, then they would tell us that for some of them, they said, I didn't see I wasn't with my partner. So that's why I didn't see a need. Others said they were anxious to utilize either public transport or the clinics because of COVID. Other ones experienced that public clinics were not providing sexual reproductive health service as the nurses either focused on COVID. Sexual reproductive health services was seen as not essential. Clinics were running out of stock, and clinics in rural areas were not user-friendly. Remember, the number of the women without disabilities come now from campuses where they really experience user-friendly clinics, and now they're back in the rural areas. There were some reports of miscarriages and terminations of pregnancies with very little assistance for those women. We also saw that sexual reproductive health service use after the hard lockdown went slowly up, but really gradually. And we definitely saw a difference in the women with disabilities and how they access these services. They either did that with family members or friends, or they sometimes had to overcome communication barriers in very creative ways. And I'll give you 2 examples here again. So the nurses, took COVID-19 patients more. So they were the essential patients rather than us, who came for injections or other prevention methods. They said it's not essential. They don't take us serious. If you want to prevent, come back after the pandemic is lower down. That's a woman without disability. Then a deaf woman tells us here, so nurses at the clinic don't know sign language. It is very difficult to communicate with them. We write on paper to communicate. Now, when we came to contraceptives, a very, very similar picture emerges. We asked them about all the different potential methods. And again, before the lockdown, women with disabilities access that less than women without. And then there's a drop at interview 2 that is after the hard lockdown. When we asked them again, very similar reasons occur. So I wasn't with my partner, so I didn't see a need. Sexual and reproductive health service were perceived as non-essential, and I didn't need to access it because I only slowly needed it later. And again, women with disabilities were less likely or were in the need of support of family members. So 2 examples that I echo what I said just before. I did not even ask about it, contraceptives. I just said I will continue when I'm back in Durban during level 5 in 2020. I didn't really go to get my pills. I didn't go to the clinic. I was not sexually active. So I was not going to go for my contraceptives or my PrEP pill. That's an HIV prevention pill. That's a woman saying without disabilities. Another woman with disabilities tells us here, before COVID, I got this 3 months injection. I point to it on a poster. So here we see exactly the communication barriers again. And now, I buy condoms and practice early withdrawal to prevent falling pregnant. So we see a shift in the prevention methods. These young women use either none or different ones. When it comes to menstrual hygiene, a very, very different picture emerged. So most of these young women use sanitary pads, and before and after the lockdown, they had access to it. There is an increase in some of them not using it, but that is really related to pregnancy and in one case to the use of injections. So when we asked them about it, they really echoed, yes, no, I can access sanitary pads. I don't have a problem with that. They reflected that they could get it from the clinics, but also from some of the emergency responses or from family members or by it themselves. So 2 examples. I had no challenges obtaining sanitary pads. There were people from the Department of Health who were distributing pads around my home at bus stops, halls, and clinics. That's a woman without disabilities and a woman with disabilities. Intellectual disability is very similar. I was using sanitary pads that my aunt bought for me and had no problems doing so. When it comes to reporting violence, we had very low levels. I will say something to that just now. But again, women with disabilities have reported before and during the lockdown, more experience of violences on in different types than those without disabilities. But I think it's more interesting to talk about why there is that reporting. So first of all, the little reporting even before the lockdown is probably related to the method of investigation. We had to use, remember what we had to use phone calls. And during the lockdown, it is also they went actually with their partners. So in some ways, that was a protective method. What we did notice in the qualitative work is that the participants with the disabilities really went through traumatic incidences and were quick to accept that abuse, or were disencouraged to report it, or took simply the blame. And here are some quotes. So the first one is referring to her boyfriend, who is forcing her to open the phone and then slaps her when she doesn't do that. The second incident is referring to a woman with physical disabilities who is raped in a student dress. So this is clearly referring to before the lockdown. And then she lets this guy go. And because that is the case, no one afterwards wants to believe her or help her to report it. But this rape has a particular serious impact on her health, and she has to have another operation. So now we have relatively little reporting in terms of how pandemic South Africa is in terms of violence. But there are some other quotes in these young women when they speak about the others and say, you know, there's more violence now. We do need to have the services to respond to this. So there's certainly something that lingers that probably with other methods can be trickled down better. And now in closing, what would I recommend? First of all, there were some things that worked. So for instance, the campus clinics seem to be user-friendly. Women seem to be able to access menstrual products in this particular group, okay? And the grants, emergency food supply and subsistence farming seems to go some way to support livelihoods. But there's a lot to do. So first of all, increase the number of user-friendly clinics. I think that's something echoed in many other presentations. But then also make sure that young people have access to internet data and e-learning for all, and that is accessible for all, the universal design to learning and teaching. We need the mental health and wellness services that reach young people before and in crisis, and we need to make sure that that is accessible to all. We may include chat functions for the deaf as well. We need to improve accessible clinics as well as GBV services. Maybe start with a disability audit and assessment and an action plan per facility. We need to innovate on how these services can be delivered. We have learned about information sharing virtually. We have to now learn during COVID how to deliver services to the house. Maybe there's something for us to learn. We need to review the purpose of the disability grant, because this really can't be a poverty grant. It needs to be allocated to compensating disability disadvantages and needs. And we also need to think about what approaches before and in the crisis can actually decrease gender and disability inequality, and that double load of work that particularly these women experienced during the pandemic. With this, I would like to thank all my co-investigators and the COVID Collective, SAMRC, and the NMAH for funding parts of this project. Thank you very much.
Thank you very much, Jill, for that comprehensive presentation. It is now time for the question and answers. I would now like to give the floor for questions to the speakers. Nokolo will monitor this on our chat box, and if we have some questions there. So while I'm talking and asking some questions, you can just raise your hand or just type them on the chat box. Don't forget to unmute yourself when you do speak. For now, I think I will ask a question to each of the speakers while we wait for more questions on the chat box. So to Dr. Pravina Sukhrajeni, I would like to ask you a question. How can the new research findings from the COVID pandemic inform the draft disability policy for South Africa?
Okay, and I just want to clarify, there is actually no draft disability policy in place. We have the white paper on the rights of persons with disabilities that was approved by Cabinet in 2015. And as I indicated in the address, the UNCRPD, the provisions of the articles in the UNCRPD is embedded in the white paper. I want to say that all the research that has been done and the recommendations, the focus going forward is to mainstream disability and ensure that all policies that are implemented and developed, etc., in the various government departments are always inclusive and mainstreaming disabilities in terms of their planning, their priorities, their implementation, monitoring, evaluation, etc. And as you know, many the speakers have said, it was that disability came as an afterthought when it came to looking at how we would implement the various regulations, etc. And we want to avoid this, and therefore going forward, we're going to advocate for all and lobby, making sure that all these recommendations are embraced and taken on board by the various implementing institutions. And we need to help giving them technical capacity, expertise, etc., to ensure that when they're developing departmental policies, that they include disability in included from the beginning, and ensure then that disability is mainstreamed in every sector of policy development going forward. I hope this provides some clarity.
Thank you so much for that response and clarity, Dr. Pravina. I would now like to ask Dr. Tim Hart a question. So you showed us that the communication changes of people with disabilities. What innovations could help to make information sharing more accessible to all people, including those in resource poor settings?
Thank you, Yolanda. I think a simple answer to that would be to have captioning, okay, closed captioning freely available on televisions. It seems that television was the most commonly used source of information. There were multiple sources, but that was the most commonly used one. And if one did, for example, these press pieces and the monthly meetings are planned quite far in advance. So one could then look at ways of presenting the captions in all the official languages. It may well then become a challenge for those people who cannot see, because the language would be in English only. So somehow there needs to be some sort of system, and perhaps this goes back to SABC and its belated failure to roll out these television top boxes, but that could all be used. If we're talking about innovation, I'm talking about high tech now, I suppose, but there are many ways that it could be done, but at the moment we seem to only have sign language interpreters, and even there was a challenge with people not being able to see them clearly at all times. And I don't think that this was to do with visual impairment, but I think it was to do with where they were being positioned on the screen. So I think it needs a lot of tweaking. Television is clearly one of the main broadcast mediums during the pandemic, and one would then just have to look at how people can hear and see what the messages are that are being put across. Thanks.
Thank you, Dr. Tim, for those recommendations and innovative ideas. I would now like to ask Dr. Jill, Professor Jill Hannes-Hancock, a question. You showed us that women with disabilities are less likely to utilize sexual reproductive health services. What innovations could improve access?
Thanks, Ayanda. Yeah, I think there's two things. You have to know about the service and that you can access it, and then the service itself has to be accessible. And I think we can look at innovations on both of those. So when it comes to the services themselves, I already said they really need to maybe undergo a disability audit. That might be a little bit difficult for some to maybe start with a smaller, easier tool. Yeah, the MRC is actually developing one together with the Department of Health and CDC in order to enable facilities to identify their gaps in disability accessibility and make improvements by themselves, not waiting for a big brother to help do that for us. The other thing is to really sensitize healthcare workers about it. And I think we will see from Jack a really interesting innovation also developed during COVID. So I'm not going to say much to that. And then the last thing is persons with disabilities themselves, they need to have knowledge about sexually reproductive health. So even in our research, we really found it difficult to talk about this topic, not just because the topic was difficult, also because the vocabulary was difficult. So that speaks to education. And there are some interesting innovations that have been tried out. One you will hear from Jacqueline just now about, which gives information directly in the hands of young women. The other thing is to make sure that at school that things are taught. First of all, that, for instance, comprehensive sexuality education is included in the curriculum also for those children that have disabilities. And for that, a teacher needs to learn how to apply universal design to teaching and learning. So how do I teach the same content in a way that is accessible to people using very different senses to understand the information? And then the third thing is using technology to how can you provide information maybe with WhatsApp-based interactive webinar. Or not webinar, interactive group chat that is actually suitable for young people in terms of the mode that you use, how you use it, and the data it consumes. So I think those are the things that we can look at to innovate. Thank you.
Thank you for that, Jill. I don't think we have any more questions currently, so I think I will.
There's one question.
There's one question. Sorry?
There seems to be one hand.
Okay.
Is Cirola and a Petronella. There's actually two.
Okay. Please read out the questions for me.
They have their hand up, so they would have to unmute themselves.
Please unmute, and then if you would like for us to see you, and then just ask your question.
Petronella speaking from Department of Communications and Digital Technologies. I am not going to open my video because I have a vision impairment and I'm just not sure if I'm going to be able to navigate properly. So please accept my apology. I just wanted to comment on the issues relating to technology and especially with regards to digital migration. I think Tim made a comment in his response. I just wanted to indicate that from the Department of Communications side, the process towards finalizing migrating from analog to digital is to be concluded by the 31st of March, which is tomorrow. And all provinces will be then switched off in terms of analog signal and will then be going over to digital signal. And then also just to indicate that the department during the lockdown period, we did put out regulations in terms of access to zero-rated websites, especially educational websites, so that students and learners could access information at a zero-rated level. We also put out regulations to the operators such as MTN, Vodacom, and so on, to look at how they ensure accessible information, sharing information on their platforms, as well as on the media, the social media platforms. So that's what was done. And then what is being done now in terms of digital migration, as I indicated, it is being concluded, and citizens are encouraged to register with their local post office to access the digital set-top box, to enable them to have digital signal once the migration is concluded. And then also to indicate, as part of the work that we are doing to reduce the cost to communicate, there is also a process underway to look at how to work with providers in terms of providing access to data at a lower cost, but that is still a process that's underway. So I just wanted to clarify some of the issues that was raised in terms of communications and digital technologies, since that is the mandate that our department has. And then also just to indicate that going forward, the department's aim is to ensure that we use technology to enable persons with disabilities to have access to information. And if there are people that are having challenges, they would need to inform the department so that we are able to respond to those needs appropriately. Thank you.
Thank you very much for that response. While we are waiting for Cyril to write their question on the chat box, I will go over to the research uptakes and examples, and we'll take your question after you have written it. If anyone else has any questions, you can continue to write them on the chat box and we will monitor this. And thank you all for the contributions. Now it is important that research is used to inform policy and practice. While much of this knowledge translation still has to happen, 2 examples will be shared now from groups who have worked with the Forgotten Agenda team and used their and other research to develop sexual reproductive health and rights interventions during the COVID-19 pandemic. We will now hear from representatives of ARC, Jacqueline Kashula, and thereafter from Dr. Jacques Lloyd from the National Department of Health. So Africa Rehabilitation and Research Consultations, the ARC. Jacqueline Kashula is a Monash University graduate with a bachelor degree in public health. Besides her role as an administrative assistant, disability health, HIV, TB, NCDs, alongside Dr. Jacques Lloyd with the Department of Health. She is the project coordinator for the Africa Rehabilitation and Research Consultants and has been the project lead for Her Voice Fund projects undertaken by ARC NPC, a global fund project funded by VIIV Healthcare, Positive Action, and Y Positive Global. And then the National Dr. Jacques from the National Department of Health is living with quadriplegia for 35 years following a water skiing accident. Dr. Jacques Lloyd is one of the directors of Africa Rehabilitation and Research Consultants, a non-profit company in the Western Cape focused on the health and the rights of people with disabilities, as well as in the Department of Health, Deputy Director, Specialist Advisor for the Disability Health, HIV, TB, NCD. Dr. Lloyd completed his master's degree in Europe, focusing in adapted physical activities, physical education, rehabilitation sciences, and physiotherapy, and his PhD with the University of Western Cape. Hereby his thesis focused on behavioral and protective factors contributing to the risk and vulnerable to HIV/AIDS among individuals with spinal cord injuries. So I'd like to present these speakers to you. I guess we'll start with Jacqueline Kashula from the ARC.
So as Ayanda mentioned, for Afrique Rehabilitation and Research Consultants, so ARC's research uptake examples, I'll be going through ARC's project with Her Voice Fund, which is a global fund project funded by VIV Healthcare Positive Action, as well as Y+ Global, which is the global network of young people living with HIV. Okay. So just a bit of a background on the Her Voice Fund and ARC projects. So during Her Voice Fund Year 1's project, which was from 2020 to 2021, ARC conducted research on the sexual and reproductive health and rights, so SRHR, needs and challenges of adolescent girls and young women with disabilities in South Africa. From the Year 1 research, there were 2 priority areas that were identified amongst the adolescent girls and young women. The first was that there was low to limited knowledge that the girls and young women had on SRHR. And the second was that there was low to limited access that they had to SRHR related information and education, but also to services, programs, and groups. And this was due to a number of social, economic, and physical barriers that they faced. So from this, to address the 2 priority areas that were highlighted in the Year 1 research, ARC decided to implement activities as part of the Her Voice Fund Year 2 project, which was from 2021 to the beginning of this year, 2022. The project focused on resource development to address the highlighted needs and gaps in the Year 1 research amongst adolescent girls and young women. So as part of one of the activities and subsequent outputs of the Year 2 project, ARC is developing and still currently reviewing a SRHR guide for adolescent girls and young women in all their diversities, but as well as for their caregivers and their families. So in order to provide them with information on SRHR and education, but also to provide them with access to services, resources, and helplines, including those for help and support. Assisting in the development and review thus far of the SRHR guide has been adolescent girls and young women themselves. It's also been peer support and facilitators, as well as the South African Medical Research Council and UNAIDS. So this has just provided a more rounded and holistic approach to the development and review of the SRHR guide. But obviously, as we progress, we would like to have more partners on board to review and develop the guide. So the topics that are covered in the guide so far are obviously those on sexual reproductive health and rights, but including those on contraception, women's healthcare, maternal and newborn healthcare, sexually transmitted infections, HIV, and violence and abuse. The guide also provides information and resources on services, organizations, facilities, and helplines that offer healthcare, but also help and support. One of the key components of the guide is actually its use of icons to make it more user-friendly for those that are using the guide. Currently, we have 5 icons that are used throughout the guide. The first is a video icon, which simply highlights videos on SRHR topics that AGYW and users of the guide can access for more interactive information sharing. The second is the light bulb guide, which highlights additional information on certain topics, including additional information on services, facilities, and products that can be accessed by adolescent girls and young women. The third icon we have throughout the guide is the Lady of Justice icon, and she simply highlights when rights are being mentioned. So this includes our sexual and reproductive rights as well as human rights. The fourth icon we have is the speech bubble and book icon, which simply symbolizes a dictionary. So it provides explanations and definitions for words and phrases that may be a bit more difficult or adolescent girls and young women may not have come across. So just to make the guide a bit more user-friendly and simpler to understand. The last icon that we have is the disability icon, and it simply just highlights when information about and for young women and girls with disabilities is being mentioned. So as you can see, I've just given a few examples here of where the icons are being used. So you can see at the top, the video icon is indicating a video that can be accessed on contraception. The light bulb icon to the right is indicating additional information on services that are actually provided by Clicks Clinic and Dischem's Wellness Clinic. And then the Lady of Justice icon to our left is indicating rights, specifically contraceptive rights that everyone has. So the end goal, the main and end goals of the guide is simply to have it accessible on online platforms for adolescent girls and young women with disabilities, as well as for their caregivers and families, simply as a means to freely access information and education on SRHR, but also information on services, helplines, and resources that are available. The second goal is to have the guide shared with partner organizations and stakeholders, so they can therefore go and share it with their communities and networks of adolescent girls and young women, therefore increasing the reach of the guide. The last that the project is looking at is we would love to have the guide be more accessible and inclusive. So for example, having the guide in Braille formats, having the guide in audio formats, just to meet all of the needs of adolescent girls and young women in all their diversities. Currently, as I mentioned, the guide is still being developed and reviewed. We are looking to have the guide finished towards the end of the year, preferably August. But once the guide is complete, it will be available on ARC's website under resources and under the Her Voice Fund projects. So anyone who freely wants to go access the guide, it will be up there. It doesn't just have to be adolescent girls and young women. Like I said, it can be caregivers, family members, and even other organizations. So yeah, thank you so much for having me.
Thank you so much, Jacqueline. Over to you, Dr. Jacques.
Hi, everyone. Joel, thank you very much, Joel. Yes, thank you very much, Jacqueline, for that presentation, and for all the other presenters for their presentations. From National Department of Health's perspective, it just shows how much still needs to be done with regards to all the challenges that has been highlighted. As introduced, I'm at the moment with the National Department of Health looking at inclusion of people with disabilities within various programs within the department. We know that the disability inclusion within the Department of Health has been a huge challenge. And we were really happy to be made aware of the fact that the department has started developing a sexual and health and reproductive rights course that would be hosted on their online knowledge hub. So at short notice, Jill, you can stay with the first one, it's fine. So at short notice, I requested the support of various organizations and individuals to assist with the compiling of a disability-focused model to address SRHR disability-related challenges. Next slide, please. This resulted in Module 11 focusing on disability and SRHR being included within the training package. The training package provided by the department on the Knowledge Hub provides for a comprehensive framework for training of healthcare providers on SRHR in South Africa. The training package is online. It is free and consists of an 8-week course with the potential of, once completing the course, earning a certificate and achieving 60 CPD points. So we hope that that will really encourage people to access this platform. The course is suitable for nurses, support staff, medical interns, community service doctors, and basically all community health workers that wants to access it. In total, there are 14 SRHR related modules, of which one of these modules, module 11, focuses on disability and SRHR. Next slide. Module 11 consists of 4 training sessions in total, of which one session is part of Module 1, the introductory session. Why we did this to include a session on Module 1 was that because Module 1 is a compulsory module that needs to be completed by everyone who wants to access the course. And here we focused on disability etiquette, we focused on access and communication to make sure that once a person has started with a course, that they actually do understand how to communicate with people and the challenges that people with disabilities are having. The other 3 sessions falls under Module 11, and each session includes a post-assessment to test the course attendees' knowledge. All sessions were provided in audio format to ensure that course attendees with visual impairments were included. Next slide. Session 1 of Module 11 focused on disability rights and SRHR topics. This included legislation related to disabilities such as the CRPD, the White Paper on the Rights of People with Disabilities, the National Development Plan 2030, and the current NSP, which is very important so that people can actually understand what the challenges are that people with disabilities have, but also understand their rights and how it can be addressed. Next slide. So this session focused on disability and sexuality versus stigma. This topic covers topics such as disability and sexuality, heteronormativity, and stigma and myths around disability and sexuality. Session also covers services and needs for people with disabilities, as well as focused on the Venus approach, which discusses some of the alternatives to sexuality and sexual expressions. We also wanted to make this very practical so that people can understand what the challenges are that people with disabilities are experiencing. So we made use of case studies to explain the common myths and misconceptions about people with disabilities and sexuality. Next slide. Sorry. So in the next slide, we focused on rehabilitation and disability. Sorry, Joel. No, that's it. So here we focused on disability and rehabilitation and the challenges with regards to the capturing of data and also how health workers are approaching rehabilitation and disability. This section focused on a multi-sectoral strategy that can be applied to address the rehabilitation needs of people with disabilities. And there we looked at some modules like the CBR matrix and other ways of approaching this. It also focused on indicators and screening and diagnostic tools with regards to that health providers can use to improve data capturing and to better be able to indicate the needs of people with disabilities in the field itself. And we've heard quite a few of the speakers earlier mentioning the challenges that we have with capturing data and access to data with regards to people with disabilities. So we feel that this needs a lot more work and a lot more focus to develop strategies and also to inform people on how to use it. Next slide. So lastly, I just want to thank our partners, because it would not have been possible to put this up and at such short notice. And I want to thank the South African Medical Research Council, University of KwaZulu-Natal, Wits University, ARC, and all other contributors to this, to make this possible. We also hope that this is a start of a process that we can build upon to improve the inclusive approach of disability and disability-related challenges that we are experiencing within programs within the National Department, and that with this, that we can actually also focus on other programs within the department and create online access for that. Thank you very much.
Thank you so much, Dr. Lloyd. Nopolo, are there any questions on the chat box?
We have got a question from Cyril Machabe for Dr. Pravina Sukhrajeni. It states, how is the Department of Women, Youth and Persons with Disability ensure employment of persons with disability in the line with the Job Access Strategic Framework, whose responsibility is that to ensure that people with disabilities are given employment opportunities in the public sector service?
Thank you. Thank you for that question, Sarole. I just want to clarify, the role of the Department for Women, Youth and Persons with Disability. And, that the role of the department is an advocacy role, and also to try and coordinate performance reporting of the various government departments and public entities. Now, just to say that, one of our key roles is to try and ensure that the various indicators outlined in the white paper, outlined in terms of the medium-term strategic framework, we are looking at mainstreaming it within all government departments' annual performance plans. So currently, we ourselves will not be able to, as the department, force departments to employ persons with disabilities in accordance with the job access framework. However, we are ensuring and guiding the Department of Monitoring and Evaluation, Performance Monitoring and Evaluation, to ensure that all the departments have indicators to ensure that persons with disabilities, the targets of employing persons with disabilities, are met. And then these departments would have to report on their performance in terms of whether they are employing persons with disabilities and whether they are actually providing them with the relevant reasonable accommodations, retention mechanisms in place, etc. So that is our role, and this is how we intend to ensure that it's mainstreamed across departments, it's included in annual performance plans of the various departments, in ministers' performance agreements, etc., so that we're actually able to roll it out and report and monitor accordingly. Thank you, Ayanda.
Okay, thank you very much. We are coming to the end and we have run out of time. Thank you very much for this rich discussion. We With this, we are now at the end of our third Forgotten Agenda webinar. We would like to thank our collaborators and presenters for their input into this webinar. We would like to also thank the COVID Collective for their support for our research and the webinar. We have heard today why disability and data is important before and under crisis. This work highlights how previous inequalities have been enhanced under crisis, but also how people have responded creatively and developed intervention to strengthen inclusive progress in the years to come. With this, I'd like to thank you again for being a part of this webinar. While we're closing, we'll just like to draw your attention to the research outputs of our participating organizers. Thank you very much. Thank you to everyone.